Well, thank you so much. I have a lot to live up to, I guess. There's no violins. I'm not playing at the end. I hear there's a violinist and a guitarist. One of them is not going to be me. So I wanted to provide a high-level overview of surgery for neuroendocrine tumors. Just as a show of hands, how many people in the room have had surgery for the neuroendocrine tumor that you have, or your caregiver that you know has had surgery? Okay. All right. I'm going to be focusing mostly, I'm a GI cancer surgeon, so I operate on patients with pancreas, liver, bowel tumors. I'm not a thoracic surgeon, so I saw some patients with lung neuroendocrine tumors. You're not going to be hearing about that. So this is going to be focused on surgery for bowel, pancreas, and liver neuroendocrine tumors. So let's move forward. Let me see how to advance these slides. I guess I'll move this way. All right, so these are my disclosures. They're not relevant to the conversation today. You know, I think everybody in the room is aware of the fact that neuroendocrine tumors, often referred to as the zebra in most medical diagnoses. You know, we have our little lanyard here with a zebra on it. And while neuroendocrine tumors are rare, there are still 12,000 new diagnoses of neuroendocrine tumors every year in this country. But because of the increasing armamentarium of treatments, the safety and efficacy of surgery in patients who present with localized disease, meaning amenable to surgical resection, and the prevalence, right, of the disease, there are now this number is nearly 200,000 patients who are living with neuroendocrine tumors. And that number might even be higher, right, Aman and colleagues, in this country. But it's a double-edged sword. Because it's rare, and because of the fact that it's very different, for example, if you have a pancreatic neuroendocrine tumor, patients who come to me are fearful that this is going to be a pancreas cancer, and we have to counsel them. This is very different. It's a very different entity. But because of that, because of its rarity, there's sometimes a delay in diagnosis. Even providers, primary care doctors, even specialty providers don't really understand the disease very well. And thanks to forums like the Neuroendocrine Cancer Research Foundation and other foundations that are really working to promote what it means to have a neuroendocrine tumor and what these entities are, we're making progress. But because of this unfamiliarity in the diagnosis and the treatment, these often get missed. They often, patients will then say, well, that's nothing, it's a cyst or something like that. And you've heard these stories. And then we'll see them many years later, and they have full-blown disease or metastatic disease. I think it's important when we're talking about surgery for neuroendocrine tumors to talk about the anatomic location that these tumors are found in. The vast majority of these, I saw many people raise their hands with small bowel neuroendocrine tumors. The vast majority of these, upwards of 55 to 60%, are found in the small intestine. These are known as GI or gastroentero neuroendocrine tumors. And then the next two sites that are most common are lung, about 20 to 25%, and pancreas. Let's see if this pointer works. So you can see here that the size of the circle indicates, the incidence in terms of anatomic location. There are other sites. I know some of you that have either had yourself or a family member, have tumors in the rectum or the colon. There are rare neuroendocrine tumors that are found in other sites, such as the thyroid and the adrenal gland. You heard about pheochromocytomas and other types of tumors that emerge from other chains of neuroendocrine cells called in paragangliomas, and also cervix and ovary. In terms of metastasis, the dominant site is the liver, followed by the lung, followed by the bone. So the dominant site is the liver, and we'll talk a little bit about debulking for liver metastasis. You guys might have heard about that, and you might even know patients who have had those types of procedures done. It's very important, especially when you come for a surgical evaluation, for us to do a complete workup. That includes a thorough physical exam. Surgeons are not the best at doing physical exams. I cannot tell you where my stethoscope is, but I will tell you that for patients with neuroendocrine tumors, it's very important for us to do a physical exam, because sometimes we'll find lymph nodes or other things that help us make clinical decisions more so than other cancers. Lab tests are important. You guys have heard about the test chromogranin A. There are other tests like serotonin and other things. In general, if it's elevated, it might be helpful, but it's non-specific, meaning many things can increase that value. So it's something that we can track, but it's not something that we hang our hat on, meaning that if your chromogranin A is not elevated, for example, it doesn't mean that you don't have neuroendocrine tumor, right? So I'll talk about the two major distinctions of neuroendocrine tumors into functional and non-functional tumors and what that means. But if you have a functional tumor, it means the tumor is making a hormone. And you can actually look for that hormone in the blood as a marker for the severity of the extent of disease. Imaging, you heard about the dotatate scanning. This is becoming a part and parcel of the way that we not only diagnose patients, but the way that we manage patients and we track their outcomes after surgery. Most patients who need surgery will have a CT scan and or an MRI depending on the site of disease. And there can be additional procedures that we do to work up the neuroendocrine tumor in terms of where it is and getting a piece of the tumor for us to analyze what the markers are that help us make decisions whether surgery is helpful or not. And I'll talk about that in just a second. The reason why this workup is critically important, and again, I said I'll focus on the pancreatic neuroendocrine tumors and the GI neuroendocrine tumors. Again, I think that makes up the majority of the people in the room, because they have different treatment options, different surgical options, and different responses to therapy. So it's very important for us to know it's not one big bucket. The patients who have functional, remember I said there are tumors that make hormones that can actually cause symptoms. Patients present with those symptoms. Tumors that are functional usually are treated differently than tumors that are non-functional. From a surgical perspective, I'll have a slide here that'll go through the functional tumors, and most of the times we're operating on patients who have localized functional tumors, because if you can do that, you get rid of the symptoms. And but the reality is that most neuroendocrine tumors are non-functional, meaning that they do not secrete hormones, and they're often asymptomatic. How many patients in here presented completely asymptomatic? Completely asymptomatic, exactly. And so you could have a large burden of disease, and you can present with asymptomatic presentations. And so it behooves us to understand that the site, the anatomic location, and the characteristics of your tumor have implications, no doubt, on the prognosis. So it's very important for us to do this workup in a very thorough way. All right, so I talked to you about functional and non-functional. Why is that important? So non-functional tumors make about 75 to 80% of neuroendocrine tumors, whereas the functional variety about 20 to 25%. The majority of functional tumors, neuroendocrine tumors, are found in the pancreas. Why? Because there are multiple cells in the pancreas that have different functions for to maintain the homeostasis of your endocrine system. Most of the times we don't even think about our pancreas. We know about insulin, but there's many others. And these are the different cells, the G cells, alpha cells, delta cells, beta cells, D2 cells, and they make different hormones like gastrin, somatostatin, glucagon, insulin obviously being the most, the poster child for a functional neuroendocrine tumor, and then VIP, or vasoactive intestinal peptide. Each of these have specific syndromes that are associated with this type of presentation, and each of them have different presentations in terms of anatomic location. But the one thing that binds, as I said, the functional neuroendocrine tumors as a group, as an entity, is that almost always, if they present in a localized fashion, or sometimes even an advanced disease in selected cases, they need surgery because the symptoms are so overwhelming, and surgery can actually alleviate those symptoms. Now this is a high-level overview, so there's obviously caveats. And I mentioned to you the non-functional tumors. So what do we do about non-functional tumors? How do we adjudicate patients who need surgery? So we adjudicate that based on how the cells are looking. And I'll talk about grade in just a second. And we talked also about poorly differentiated cancer. So the grade is important, and the location is important. And the last thing that this is actually a schematic that I made that can help us figure out how we can approach surgery based on tumor grade. So if you have a well-differentiated, meaning that the cells look like they're not dividing very quickly and they're not proliferating very fast, so it's a well-differentiated grade 1, those patients typically need surgery. A well-differentiated grade 2 tumor typically needs surgery. Now when you get into the grade 3s, remember I showed you that table where the cells are proliferating faster. We get into a gray zone with surgery. So either the surgery may be indicated, but in some cases it's too aggressive for us to offer surgery. We often start with treatments. The poorly differentiated grade 3 tumors we typically do not operate on. Those are the neuroendocrine cancers. I didn't see any hands go up in terms of the neck patients in here, but those are the patients in which systemic therapies, because of how aggressive those tumors are, preclude surgical resection. And then I mentioned size. So the way the cells behave and the size of the tumors help us approach this. So for non-functional neuroendocrine tumors, in general, the size dictates how we're going to manage them. So there are lots of studies that have been performed on small, non-functioning neuroendocrine tumors, particularly those that are less than 2 centimeters. It's safe to observe them. That's the take-home point here. Because the operations that are required to remove these, particularly in the GI system, like small bowel tumors or pancreas tumors, the risk can be much higher than the risk of progression and dying from these cancers. And this is actually a study that just read out in the current ESMO conference that Dr. Chauhan was talking about, the ASPEN study. This was a multi-center, multinational study of nearly 1,000 patients. And they basically it was an observational study, but they looked at these small, non-functioning neuroendocrine tumors that were less than 2 centimeters, and a vast majority of them were able to be safely observed. So they were doing active surveillance versus surgery for these sporadic, asymptomatic, non-functioning neuroendocrine tumors that were less than 2 centimeters. Take-home message, without going into the details, observation was safe. All right. This will all be available to all of you. These slides will be available to all of you. I put more writing on the slides than I typically do, but this is because I'd like you to have more information. But the goal of surgery for neuroendocrine tumors is removal of all tumor. Okay? So minimize debility. I'm probably going to overshoot that by a couple of minutes, but we'll finish soon. And the point is, when you have localized neuroendocrine tumors, our goal is to cure. Our goal is to cure with surgery. And so, and most of them are successfully treated with surgery alone. But when we have regional disease, meaning the surgery has gone from the primary organ to, say, the lymph nodes, or maybe even small disease in the liver, we can eradicate that disease if we do complete surgery. And so that's really the goal. I talked about debulking. Remember I said that the liver is the main site where these bowel and pancreas neuroendocrine tumors like to go, and that's the sign of the liver. I do a lot of liver surgery. The goals of debulking surgery are to remove as much of the tumor as possible to improve oncologic outcomes. So I will operate on patients who I think I can completely remove their disease, like this type of thing. Here, I would remove this part of the liver, and I would take these 2 tumors out. This, on the other hand, very hard to eradicate. But if patients are symptomatic and those tumors are producing hormones, sometimes removing as much of the tumor as possible may alleviate some of the symptoms. And so on a very selected case-by-case basis, we entertain these, and you'll hear from Dr. Thornton and our other colleagues here that the armamentarium of treatments that are non-surgical are also improving at a rapid pace. And so we can maintain symptoms without surgery in many of these cases as well. So, small bowel neuroendocrine tumor, I'm not going to go into all of the details on the slide here. You can read this, but almost exclusively these are well-differentiated grade 1 and grade 2. Remember, I talked about the differentiation in the grade. Surgical resection is paramount in these cases. We were just having a debate. In general, at our center, we tend to remove small bowel neuroendocrine tumors because not only can they metastasize, but they can cause local bowel issues. And so cure can be achieved in localized patients. In some patients with metastatic disease, we can palliate their symptoms, particularly if they present with bowel obstructions. If a tumor is in the bowel, it can spread to the lymph nodes and cause bowel obstruction, so we can alleviate some of those symptoms. This is very interesting because up to half of patients can actually present with multifocal disease, multiple tumors in the bowel, so you have to palpate the entire bowel. This is one of the tenets of small bowel neuroendocrine tumor surgery. So that is why in those cases we tend not to operate laparoscopically because it's hard to get that tactile feedback. That's why patients, surgeons, if you've had that operation, will often do it through smaller incisions. They can bring the bowel out of the body and actually feel it. These don't respond as well to some of the therapies that I'll talk about for the pancreas. Okay, so for the pancreas, this is a little fish-shaped organ behind your stomach. There's a head, neck, body, and tail. And based on the location and whether it's a functional or a non-functional tumor, these are the typical operations that we offer. You've heard about the Whipple operation. The Whipple operation is for a tumor in the head of the pancreas. Typically, we will offer Whipple operations for both functional and non-functional tumors if they present in the head, because it's very hard to pluck tumors out of the head, even if they're small, okay? And when I talk about plucking tumors out of the head, I'm referring to this operation that some surgeons offer. I'm not a big fan of this operation, where you can enucleate. I'm going to show you a little slide at the end. You can enucleate that tumor, especially if it's small, if the grade is low and it's functional, and if it's in a favorable location, you can pluck that tumor out, almost like shucking an oyster. I don't like to do it in the pancreas because you spill pancreas juices and those patients can get very sick. But it's an option for functional tumors in the neck or in this area. In the body, you can remove this part of the pancreas, you can remove the central part of the pancreas, or you can enucleate it for small functional tumors. And in the tail, we take out the tail with or without the spleen that sits on the back end of the pancreas. And this is what some of these operations look like. It's very important to talk to your surgeon about just the long-term impacts of these operations, because obviously these are huge operations. But at high volume centers like ours, where we perform hundreds of these procedures, it's safe and long-term GI quality of life is actually very, very good. So this is the Whipple operation, where we remove the head of the pancreas and the duodenum and then reconstruct this. And this is the before and after. I talked to you about the enucleation operation. These are for tiny tumors that may have functional consequences, and they're in favorable locations. So this is just a cartoon representation of how we can almost shuck this out using our electrosurgical devices. And finally, the distal pancreatectomy that I talked about for tumors that are in the tail of the pancreas. The spleen usually sits kissing the tail of the pancreas, and so we do an operation where we remove the lymph nodes and that tail of the pancreas. Usually these operations can be done robotically, and so we offer them here as well. There are some special considerations, and I'll be wrapping up very quickly. You may have heard about adjuvant therapy, meaning after surgery, we give treatments to mitigate the recurrence. But we're trying, because of the growing armamentarium of treatments that are effective in some of these diseases, we're thinking about giving these treatments before surgery. So neoadjuvant, right here. So sometimes removing the tumor is not safe or possible initially. And in fact, Aman and I share several of these patients. But these treatments can decrease the tumor size and allow us to adjudicate whether the patient has other disease elsewhere in the body, to allow for a safe and effective local operation. Remember, surgery is a local treatment. So we have to be confident that we are operating for the right reason. If I operate on a tumor and 3 months later there's widespread disease everywhere just because you didn't vet that biology well, then we're not helping that patient. Sometimes we need a treatment that improves response, and I'm not going to go into the details, but you'll hear about this later today. You'll often see that patients need their gallbladder removed. Why is that? When we do bowel surgery, the reason to remove the gallbladder is not because there's something else for us to do on a Tuesday morning. It's because many of these patients with advanced disease sometimes need somatostatin analog therapies. those can cause the gallbladder to not work very well. So we prophylactically sometimes remove the gallbladder at the time of these operations in case those patients need somatostatin receptor therapies in the future. It doesn't happen in all comers, but we do it on a case-by-case basis, particularly depending on the extent of the primary disease. So these are the conclusions. Neuroendocrine tumors are rare, but rising in prevalence due to overall good prognosis and expanding treatment options. Surgery for neuroendocrine tumors have to be tailored decisions. Hopefully I've convinced you that they have to be contingent on size, the grade, meaning how fast they're growing, and their location. I talked about different locations. The goals of surgery must be balanced with the risks. Complete surgical resection is optimal, and debulking operations like the ones that I described in a very short period of time, such as the ones in the liver, can alleviate symptoms and sometimes, in selected patients, improve outcomes. And then the sequencing of treatments. Remember I talked about neoadjuvant and adjuvant. Those are going to be key to improve and increase the number of patients who are eligible for surgical therapies. And then biomarkers are going to be also important in understanding who is going to benefit from surgery moving forward. Thanks so much for your attention, and thanks for the invitation to be here.